Ed Bernstein Show. Now, here's Ed.
Well, you reach my age, and things start to bother you. Your knees, your hips, your shoulders, your elbows, and what are you going to do about it? Well, with me today is a doctor with some answers, Dr. Pejman Bady, who, and look, I don't want to minimize your experience because I know you work with PRP and you work with stem cells and a lot of the futuristic stuff. But for 30 years, you worked in ERs and worked in general medicine, and you've seen a lot. How helpful is that? Because often today, I've noticed that it's sometimes the older doctors who have seen it all that just have a better handle on diagnosing things.
Yeah. Well, thank you for having me on, Ed. Good to see you again. I've been practicing for 30 years, and I did family medicine and emergency medicine, and then I ended up being a medical director of a large healthcare company. So I reviewed physicians' cases. So the ER is amazing because you get everything and anything from psychic disorders to basic skin diseases, whatever. And you got to be able to be up to date and be able to respond accurately and fast. But also being able to look at and review charts and see how other doctors treat patients gives you a lot of understanding of how medicine is an art, and everybody can approach it from their own particular way. And as long as you get the right outcome, to me, that's what really is important. But it's given me a lot of information, a lot of insight to the human body in the past 30 years.
There's no better knowledge than experience. I mean, if you've seen it, you know what it is. A lot of these modern things, though, are, seem to be, I don't know, not questionable, but people are confused. And I know that now, you've taken, the old-fashioned medical practice that you did for 30 years, and now you're working with cutting-edge modern techniques like PRP and stem cell, which is really in its infancy of what it can be, correct?
That's right.
And PRP is what exactly?
PRP is basically a protein-rich plasma. It's a blood-driven plasma protein, which really helps regenerate and not produce new tissue, but the healing process and the inflammatory process of ligaments and joints and tendons and muscles and so forth.
And what is the process? You take one's own blood.
Right.
Right? You take some blood out, you put it in some type of machine. What does that machine do?
It's really a centrifuge, but it's a special centrifuge that rotates at a very high speed. And we have some additives, some anticoagulants, so the blood doesn't coagulate and become clot quickly. And then we separate that out, and we basically re-inject that back, which has got a lot of healing ability when you inject it to the issue of that you have in hand. It could be, when I call it an issue, it could be any part of the muscle or ligament, but we have to identify where it exactly is. So we almost always want to use ultrasounds, and sometimes, or a lot of times, we use a C-arm, which is a live fluoroscopy X-ray equipment. It's a very high-end equipment that we use for spine injections to be able to target exactly where we need to insert the PRP or the stem cells.
Right. Now, is PRP more effective in certain types of injuries?
Absolutely. For more of an acute injury, we like to use PRPs. We get we do a lot of the athletes here in town, and we mostly and predominantly use PRP on those injuries. However, if those injuries become chronic, then we might want to consider moving into stem cells, which is a more long-term solution to the problem.
Before we get into stem cells, let's finish with the PRP part of it. So you work with a lot of athletes. I know, because I've done it myself in my knee, I know that it has some validity in my knee. Now, but I've also noticed that, it works for a long period of time, but it doesn't last forever with my knee. Is that because my knee keeps getting more arthritis or getting older? Or, but it seems to help at the time.
That's
and then,
right.
maybe 9 months, a year later, all of a sudden my knee starts to bother me a little bit, and because it's arthritic.
That's right.
Right. So, is it time now for another PRP injection?
For you,
Yes.
stem cells.
I mean, okay. Oh, okay. Well, I haven't. But PRP. Before we get to the stem cells, 'cause I know that's a more permanent type of solution.
Right.
Right. The PRP is it meant to be temporary, or is it meant to just facilitate the healing? And as soon as another problem arises, you're going to have, an issue.
That's a great question, and that's a question we teach other doctors as well, and that's a question that we go back and forth. And when is the right time to go from PRP to something more long term? So it is really meant to be a short term solution. So when you have an injury which is in a ligament or a pulled ligament or a tendon or that sort of thing, or a muscle, that is a temporary issue that PRP could help get it to heal faster and reduce the inflammation quicker so the patient recovers quicker. As far as the knees go, it does work most of the time temporarily, where you reduce the inflammation around and inside the joint and it gives some mobility to that joint. But usually that wears off because it's not long lasting. However, I've had patients that we put in PRP in their joints, and they're good for years, year or 2 or 3. But in most cases, patients come back in 6 to 9 months or 10 months, kind of like you. And depending on how chronic their disease process is, they'll come back sooner. So someone who's got a really arthritic knee, we can get the inflammation down with a PRP, but the arthritis will show up sooner than someone who's got less arthritis.
Yeah, that arthritis is hard to beat arthritis, huh?
It is.
So other than the knee, I had recently, about 3-4 months ago, I partially tore my rotator cuff. Is PRP helpful for that?
Yes. It's a partial tear, so it induces healing. But when it's a shoulder tear and it's going to be something that is going to be long term, then we start oscillating towards stem cells again, and depends on the level of the tear. One option would be start with the PRP and see how the patient resolves, or you would resolve. And if it doesn't resolve, then we can go to the stem cells. I'm a big advocate of stem cells because I've done it on my spine. For me is the risk to benefit ratio. And if you're going to be going inside somebody's shoulder and you're going to be putting needles in there, I'd rather do stem cells, which I know that the outcomes are more long term. But in some cases, PRP will do the job. So it's very surgeon dependent, and is really where you say experience comes in, that you can really feel and understand the patient and what we could do to get the best outcome at the time with the least amount of risk.
And I understand now they're using PRP to grow hair.
Oh yes, yeah. And actually, it does really well. We do that in our facility as well. It does well with the skin and the hair because what PRP does, and again, the resolution of the problem is to increase vascularity and blood flow, right? So that's how you get blood flow to the injured area and to the hair and to the face. So when you have blood flow to the follicles, and again, that's also surgeon dependent because you have to get the injection right. It's not as superficial as people think. It's got to be a little bit deeper, right where the follicles are. So increase the blood flow to the follicles, you have hair growth. We've had great outcomes with hair and facial PRP.
And when you say facial, this would be for wrinkles or scars or what?
Yes.
Yes, all
Yes.
the above.
Yes. So whenever you need a healing process, scarring is a little different. You have to irritate that area before the scar starts going away. But yeah, the wrinkles, collagen. So whenever you stimulate any kind of a follicular end, your collagen also increases.
Is this what they call the vampire facials?
It is.
Which is essentially, can you explain what that is?
Yeah, basically same thing. We get the PRP, we get the blood, and they go and inject multiple areas in the face, and then they do some sort of abrasion, and they put some topical PRP, just put the PRP over after you've done an abrasion or mild cuts on the face. Different people call it different things. For a facial PRP, the way we do it is we go deep injections in the skin, and then we do the external stuff on the outside with the PRP.
Okay, so what are the recommended areas of the body? I mean, you use it for cosmetic issues, you can use it for knees, you can use it for shoulders, hips, I would suspect?
Yes. There's a confusion that you talked about at the beginning of the discussion. Really comes, for me at least, from how a lot of people use the word stem cells for treatments of things that not everybody's comfortable with, certainly not the FDA. We use the FDA guidelines, and we are a part of an IRB study, which FDA approves kind of the stuff that we do. But the whole progress and evolution of what we do with the stem cells and so forth, for us, is limited to derm, which is hair and face, orthobiologics, which is joints and spines, and vaginal and penile. Those are what we know has been proven. We really don't do any of the IVs. We don't do anything that for us has been not 100% level of accuracy and not enough studies done on them. We don't touch it. We don't want to do it. Right. We just do what the FDA approves and has allowed us to do.
So you can actually inject this into a penis, and
absolutely,
and it helps with erections, I would suspect.
100%.
Wow, is that painful? You've never done it.
Well, no, I've done it.
But you've seen it.
We've done the procedure. Again, it's surgeon dependent, right?
Right.
So if you have a nice block, dorsal penile block, which kind of blocks the nerves, then it really is painless for the patient. But you have to do it right. You have to have experience in doing it. But what it does is, again, blood flow. An erection is a surge of blood flow, and that's how you get erections. So if you have more vascularity, especially patients who are diabetic, they have great outcomes because you regenerate new cells and they grow.
Wow. Now the stem cell is different in a lot of ways because you're not really, I mean, the stem cells come from various places, right? You can use one's own stem cells from their fat, I guess. And then there's stuff going on in other countries we can talk about in a minute. But typically, you're trying to get the stem cells from somebody's own fat areas around their belly. Is that correct?
The stem cells are divided, as far as I'm concerned, into two sets. One is autologous, which is coming from the patient, and one is an allograft that's coming from an outside donor, right? We've been doing this for a while, 6.5 years, and we've done all of it, including the outside world material and autologous, and the outcomes. When you do thousands of patients, you see the trend, and we keep a tab on all of our patients. Now we have good studies internally to show that our outcomes on the autologous are so far greater than all the umbilical, placental, or exosomes that we predominantly just do autologous in our facility. Sometimes we use stuff from the outside if the patient has cancer or under chemo or some situation that we don't want to use the bone marrow and they don't have enough fat or we don't like the quality of the fat. Then we go to the outside world. But the studies that we're getting at least are showing 82 to 86 percentile on the autologous, which is the fat or bone marrow, versus 20 to 30-ish percentile on the external stuff. So we hardly ever use it.
Right. So, and you use that on the same body parts that we're talking about with PRP, or different body parts?
Same body parts. Same body parts. But if you come in with an arthritis of the knee, which is probably 70% of what we do, I have arthritis in my knees, is that we would love to use fat adipose. Still has a slightly better outcome for the larger joints. And we predominantly use bone marrow for the spine.
And look, it seems, I've experienced this myself, so I know that there's a validity to what you're saying. I also have a daughter who has been through both the PRP and through the stem cell, and witnessed this myself as well, where she had an injury to her Achilles tendon that from cheerleading, and she was in a boot for most of her life growing up. I mean, just wearing one of those boots because it had to rest her foot, and she had several PRPs. They worked for a little bit, but not well. Then she went, you guys did a stem cell with her, and she has not had any issue, any pain for years. I mean, it was a cure in my book. So I know it works. But insurance is not really covering this, is it? I mean,
no.
What is going on with that? Because it seems to me, instead of having a lifetime problem and treatment with an Achilles tendon issue, my daughter got it when she was a teenager, you know, it would have been 50 years, 60, 70, 80 years of insurance paying for treatments when they can pay for just one treatment and be done.
That's a loaded question,
Yeah,
Ed.
yeah, okay.
But I will respond clearly to this, because I sat on the other side. I was a medical director of a very large healthcare company, and I managed hundreds of docs. Okay. And if you reverse the tables and look at it at a payer's point of view, and but before we go there, some insurances in Europe cover it.
In Europe?
In Europe, not in the U.S. Yeah. But, and it's only in some countries. So you're looking at smaller countries. You know, U.S. once something is put in effect, you got, 300 and 400 million people that are going to get affected by this, and the government and so forth, and insurance companies, which are, big, the big elephants in a room. So from a payer's point of view, if you have, myself is included, I'm a patient. I'm a spine patient that I needed spine surgery. My brother, who's a very well-renowned spine surgeon, recommended for me to do spine surgery. I couldn't walk, and I had a foot drop. That is a surgical case. I mean,
An insurance company would pay for that.
Pay for the insurance, right? But I, as a patient, refuse. And I told my brother, there's no way you guys are going to cut me from the front and get a vascular surgeon to put my vessels apart and put a cage and then close me up, rotate me, and do that again on the backside, just for it to come back the next level in 2 years from now. And again, the next level, spending 10 years of my life in surgery and physical therapy. I'm not going to do it. So we did stem cells on my spine about 15 months ago, and I have a little numbness left, but I'm back to my normal activity. It changed my life completely. Patients like me, 99% of patients will opt out from surgery, meaning that the payer would pay for 1% or 2% or 5% of all those cases, that 100% of those would do a stem cell procedure. So the cost for the payer to pay out for 100% of the people to do this procedure is significantly higher than doing the actual spine surgery for that 5%. I believe that's the real reason behind it. There's also hasn't been studies that are FDA approved and so forth, but a lot of that is political. And look at the vaccine. Look at the COVID vaccine. When people wanted it, it got approved in 2 seconds, but normally it takes them 20 years to get a vaccine like that out. So that's my personal belief.
So where do you see the future of that going?
Of what?
As far as insurance companies paying for those kind of procedures?
I believe that there's going to be insurance companies that are going to be elite insurance companies that are going to pay for alternative medicine.
So in other words, you pay a different premium, buy into a different program, and
yes,
you have those types of coverages.
Yes, it's not there yet, but I believe it's going to. I would love for that to happen. We need to look. I'm a traditional medicine guy. My dad's a doc. I come from generations of doctors, right? But 100 years ago, anesthesia was a bottle of whiskey and a stick in your mouth. Now you go in and you wake up like, oh, you did the procedure. We're evolving, and this is part of our evolution. And us as physicians, also a professor of medicine at 2 schools, us as doctors, we're rigid. Change is not a big thing. We don't like change, and rightfully so. We want to make sure we have the outcomes for our patients, right? Yeah. So I realize that, but the needle is going to start moving pretty soon.
Yeah. Although, you can go, and I see this all the time, you can go to a foreign country, Colombia, South America, they're offering stem cell procedures, which they essentially are getting, my understanding, from umbilical cords,
that's right,
which is not lawful in the United States.
It's not.
And that's political, right?
Yeah, it is. Yeah. But the FDA has stepped on a lot of the centers that are doing umbilical, and rightfully so, because there's a lot of centers that are just buying umbilical cord material and having a physician assistant or nurse practitioner inject the patients, and it's almost like a business mill situation. And I realize why the FDA is doing it. If you have certified centers that know what they're doing and they use the umbilical cord or placental or exosomes properly, I think it has a space. But we're a big believer, and the FDA is a big believer of the bone marrow transplants and some fat adipose tissue transplants.
But you would think that with all this potential and all these great possibilities for these types of procedures, that there would be, some more clinical studies, better clinical studies to really guide us in what is the best way to do it.
Keep in mind that this has come along since 2008-ish. Okay. Right, Tiger Woods was the first guy who did this and just basically put this on the map for everybody else. So studies are coming. The patient mills and the clinics that are just using this to generate revenues are going away slowly, and the more reputable places are staying alive and coming out. Now the studies will show behind that. You just have to have the right centers and facilities to do studies like we do. So it's coming, but this is a very nascent industry.
Yeah. So what are your recommendations? Like if somebody is, getting in their 50s or 60s, starting to have some pain in their knee, what's their first stop? Where? What kind of physician should they go to? Arthritis? Somebody deals with arthritis?
I would go to an orthopedic surgeon, right? And I would identify who is an orthopedic surgeon that is recommended, that is relatively conservative, and then at that point, you continue treatment. Most of the patients that I see have gone to orthopedic surgeons. They got steroid injections, and they got the hyaluronic acid gel injections.
Right.
And after a while, the steroids are not going to work, and in fact, they're counterintuitive because they destroy the cartilage. And they come to us and they're like, we don't want to do surgery. We're not there yet. But the best place to go is to an orthopedic surgeon, or look at places like ours that do non-surgical orthopedics, orthobiologics. Those are the two avenues that you could go. We are biased because we don't want to do surgery. Surgeons are biased because they want to do surgery.
Right.
The patient needs to be educated and do their study and educate themselves to go to a reputable place either way.
Right. And in order to reach out to your facility, Cellaxys?
Cellaxys.com.
Cellaxys.
Cell with an axis.
Cellaxys.
Cellaxys.
And it's not all that painful. I can attest to that. I mean, you take the drawing the blood, for some people, especially my daughter, not a good thing, right? But other than that, I mean, it's relatively quick. You can be in and out within an hour, and you're probably not going to approve of this, but after I've gotten my PRP in my knee, I've literally worked out the same day. I've literally gone on bikes and worked out the same day. That's how I felt so well later that day.
Ed, I wouldn't expect anything less from you. I've seen you in hot yoga,
but not recommended.
No, not immediately. But the question should be, what's the downtime with stem cell therapy versus surgery? We have a lot of patients that are scheduled to go for a total knee replacement. They come to us and they get stem cells or PRP, and their downtime with the PRP is minimal, is none. Most of our athletes are back to work, back to the regular workouts within 7 days. As far as the stem cell, there's a bigger procedure, about 6 weeks, but we have them in physical therapy in 2 weeks. Their real downtime is 4 days with a big stem cell procedure.
Amazing. Hey, so for information, contact Dr. Bady. Look into it. I mean, this is great new science. Thank you so much, Dr. Bady.
Thank you for having me. Thank you for having me.